All right, future pharmacists, get ready for our hypertension deep dive. Think of this as your personal NETLEX prep session.
We're going to break down everything you need about hypertension, from the basics to those tricky little details that could pop up on the exam.
Exactly. We're talking causes, treatments,
Mhm.
special considerations, all that good stuff.
It's amazing how even a tiny 2 millimillig drop in blood pressure can really impact mortality.
It really shows just how important it is to get it right,
Mhm.
understand those nuances. But before we jump into treatments, let's start with the basics. How does blood pressure even work?
So remember that equation. Blood pressure equals peripheral vascular resistance times cardiac output.
Okay, yeah, I remember that.
Well, any problems with either one of those, like resistance in the blood vessels or how much blood the heart pumps out, can lead to hypertension.
Makes sense. But it's like knowing the ingredients, but not the recipe, right? I
Yeah.
mean, most hypertension is essential, so we often don't know that root cause.
It's true, we don't always have all the pieces of the puzzle, but we do know how to diagnose and stage it, and that's where we need to be pros.
Absolutely. And that starts with those blood pressure readings. You got to make sure those are accurate.
You're telling me. We have those AHA guidelines for a reason, right?
Oh, yeah, no haphazard cuff slapping.
Eh.
So once we have those reliable readings, we can stage the hypertension. Now, are we using the AHA, or JNC8 guidelines for that?
Either one can be used, but you have to remember that the JNC8 has a slightly different recommendation for patients over 60.
Good catch. Those little guideline differences can really trip you up on the NEPLX. But remember, it's not just about the numbers, right?
Mm-hmm.
We also have to consider a patient's ASCVD risk.
You got it. It all comes down to individualized treatment, not just a one-size-fits-all approach.
Okay, before we get into all the medications, we have to highlight lifestyle changes. They're not just a nice bonus. They're the foundation of hypertension management.
I completely agree, and the impact they can have is huge. Imagine this. Just losing 10 pounds can drop systolic blood pressure by 5 to 20 millimol Hg.
Wow. It's like a free blood pressure medication just from changing your habits.
Yeah.
And then there's the DSH diet. That can make a real difference too.
Absolutely. The DSH diet can take another 8 to 14 millimol Hg off those numbers. And we can't forget about exercise. Getting those heart pumping regularly can really help lower blood pressure too.
And what about alcohol? Where does that fit in?
Moderation is key. Sticking to those recommended limits can also make a difference.
So we've got weight loss, DSH diet, regular exercise, and alcohol moderation. Those are some powerful tools.
They really are. And it's not just about lowering blood pressure. These changes also reduce the risk of cardiovascular disease, boost the effectiveness of medications, and can even prevent hypertension from getting worse.
All right, I'm ready to move on to the pharmacy side of things. Which drug classes do we really need to know for the NAPLX?
Let's start with thiazide diuretics. They're usually the first choice, especially for older patients and Black patients, but there's a catch. They're not as effective when creatinine clearance is low.
So we need to be careful with those patients.
Definitely. And then you've got the ACE inhibitors and ARBs. They're the go-to for patients with diabetes, CKD, heart failure, or those who've had an MI.
I remember learning that ACE inhibitors can cause a cough.
Yep, that's a common side effect. ARBs, on the other hand, are less likely to cause that because they work a little differently. It's a good distinction to remember.
Good to know. Okay, what about calcium channel blockers? I remember there being different types with different effects.
Exactly. We have the DHPs like amlodipine, and then the NDHPs like diltiazem and verapamil.
Right, so DHPs mostly work on the blood vessels, while NDHPs can also affect the heart rate. Sounds like we need to watch out for drug interactions there, especially with meds that also slow heart rate.
You got it. You always have to be thinking about potential interactions, especially with something like a beta blocker. Speaking of beta blockers, they're not always the first choice for hypertension anymore, but they're still useful in specific situations like heart failure.
Okay, so we've got our thiazides, ACE inhibitors, ARBs, calcium channel blockers, and beta blockers. But I know there are a few other medications we use sometimes.
Oh yeah, we have a few more tools in the hypertension toolbox. Alpha blockers, often used for patients with BPH, central alpha agonists, which work on the sympathetic nervous system, and then there are direct vasodilators, which directly relax the blood vessels.
Got it. Sounds like those are for specific situations or when other treatments aren't working.
Exactly. But before adding more meds, you always want to make sure patients are actually taking what they're supposed to and following those lifestyle modifications.
Right, make sure they're actually doing what they're supposed to be doing.
And of course, always rule out those secondary causes. You never know what might be lurking beneath the surface.
Okay, let's talk about managing hypertension when patients have other conditions. First up, diabetes.
Oh, diabetes and hypertension, they're like a dangerous duo. Each one makes the other worse, and they both increase the risk of heart disease.
So how do we approach treatment when a patient has both?
ACE inhibitors, or ARBs, are usually the stars of the show because they're great for protecting the kidneys.
Makes sense. What about CKD? How does hypertension play into that?
High blood pressure is like a constant attack on those delicate blood vessels in the kidneys. It makes CKD progress faster, so keeping that blood pressure under control is absolutely vital.
So would we use ACE inhibitors and ARBs for patients with CKD too?
Yes, but there's a trick here. While they're protecting the kidneys in the long run, they can sometimes cause a little dip in GFR when you first start them.
Wait, really? That seems kind of counterintuitive.
I know, right? It's not actual damage to the kidneys, but more like a change in blood flow. So monitoring creatinine levels after starting an ACEI or ARB is super important. But usually, things level out over time.
Okay, I see why they call it the silent killer. So many things to consider. What about heart failure? We know uncontrolled hypertension puts a lot of strain on the heart.
That's right. And the RAAS and the sympathetic nervous system are both involved in how heart failure gets worse.
So are we using ACE inhibitors, ARBs, and beta blockers for these patients too?
Yep, there are go-tos here as well. They work by reducing the workload on the heart and preventing further damage.
What about diuretics? Do they have a role in managing hypertension and heart failure?
Absolutely. Loop diuretics are very common in heart failure. They help relieve those symptoms like shortness of breath and swelling. By getting rid of excess fluid, we can lighten the load on the heart.
So it's a team effort, using different meds to tackle the heart failure while keeping that blood pressure in check. Now, before we move on, what about ischemic heart disease and cerebrovascular disease? I know hypertension is a big risk factor for both of those.
You're exactly right. High blood pressure can damage those blood vessels, making them more prone to plaque buildup and clots, which can lead to heart attacks and strokes.
So is the treatment approach similar to what we've been talking about for other conditions?
Generally, yes. Blood pressure control is the name of the game, and meds like diuretics, ACE inhibitors, ARBs, and beta blockers are all commonly used. But remember, you always have to consider the individual patient's situation.
For example?
Well, let's say you have a patient with angina. Beta blockers can be really helpful because they slow down the heart rate and reduce the workload on the heart. And for a patient who's had a stroke, you have to be extra careful about lowering their blood pressure too quickly because it could potentially worsen brain damage.
Okay, those are important points to remember. Now, I know we need to talk about resistant hypertension, but before we do, are there any specific considerations for women or minority groups when we're managing hypertension?
Definitely. For women who are pregnant or planning to become pregnant, ACE inhibitors and ARBs are off the table. They can be risky for the fetus. Methyldopa is usually the preferred choice in those cases.
And I remember reading that Black patients tend to have higher rates of hypertension, and they might respond differently to some meds.
That's right. It's important to be aware of these differences and adjust treatment accordingly. Individualized care is always the goal.
All right, we've covered a ton of information already. I feel like we just scratched the surface, though.
Don't worry, we've laid a solid foundation, and we'll pick up right where we left off in the next part.
Can't wait. Until then, happy studying, everyone.
All right, let's dive right back in and tackle that tricky topic of resistant hypertension.
Ooh, resistant hypertension. It's like hitting a brick wall when you're trying to get those blood pressure numbers down, isn't it? We've talked about all the standard treatments, but what do you do when blood pressure just won't budge, even with 3 or more medications, including a diuretic?
That's where those detective skills really come in handy.
Right.
Because resistant hypertension, well, it's usually not just one thing. It's a bunch of different factors all tangled up together.
So where do we even begin? It feels like looking for a needle in a haystack sometimes.
Well, one common culprit is volume overload.
Volume overload, okay.
Basically, the body's holding on to too much fluid. It could be from eating too much sodium, not getting enough diuretic, or even kidney problems.
So if we can figure out why they're retaining fluid and fix it, that could help get the blood pressure down.
Exactly. Now, another thing to watch for are drug interactions. Certain medications can mess with blood pressure meds or even directly raise blood pressure. I'm talking about things like NSAIDs, even some over-the-counter supplements.
So it's not just the prescriptions we need to worry about, it's
You
everything.
got it. Got to look at the whole picture. And then, of course, we can't forget about those sneaky secondary causes of hypertension.
Yeah.
It could be an underlying medical condition like kidney disease or sleep apnea that's driving the resistant hypertension.
So got to rule those out. Is there anything else that can make managing blood pressure tricky?
Oh, yeah. There's this interesting thing called white coat hypertension,
Oh, I've heard of that.
where a patient's blood pressure goes up just because they're in the doctor's office.
Like they get nervous.
Exactly. It's like stage fright for blood pressure.
So how do you know if it's real hypertension or just white coat syndrome?
That's where home blood pressure monitoring comes in, or maybe even ambulatory monitoring, where they wear a device that tracks their blood pressure throughout the day.
So much more information. So, okay, let's say we've ruled out volume overload, drug interactions, secondary causes, and white coat hypertension.
Mm.
What are our options for treating resistant hypertension? What do we do?
Well, we might try adding a medication like spironolactone.
Spironolactone. Okay.
It's a potassium-sparing diuretic. Or direct vasodilators might be an option, but we got to watch those closely because they can cause a pretty quick drop in blood pressure.
There's a higher risk there.
That
And sometimes you just have to call in the specialists, right?
Absolutely, especially if things are really complex or if the underlying cause is hard to manage. A cardiologist or a nephrologist, those specialists can really help.
Okay, so resistant hypertension. It's a real puzzle, lots of pieces to consider. But now let's switch gears to those super high-stakes situations, the hypertensive crises.
Ooh, those are definitely intense. You really got to know your stuff to handle those. The first thing is to know the difference between a hypertensive emergency and a hypertensive urgency. It can literally be life-saving.
So break it down for me. What's the difference? They both sound pretty scary.
Okay, so in a hypertensive emergency, the blood pressure is really high, like 120 millimero Hg or higher. But here's the key. There are also signs that organs are being damaged.
So it's not just the number, it's the effect it's having.
Exactly. We're talking about things like brain damage, heart damage, kidney damage. We're looking for signs of trouble like confusion, a super bad headache, vision changes, chest pain, trouble breathing, or decreased urine output.
Oh, that sounds terrifying.
Yeah, it's serious. So what do you do if you suspect a hypertensive emergency?
We'll call 911, right?
Yeah, you got it. It's an immediate 9/11 situation. Get that patient to the hospital ASAP. They'll need intravenous medications to bring the blood pressure down quickly and safely. Now, with hypertensive urgency, the blood pressure is also super high. But thankfully, there's no evidence that organs are being damaged yet.
So it's still a serious situation, but we have a bit more time.
Exactly. We still need to get that blood pressure down, but we might be able to manage it with oral meds and close monitoring.
Okay, so let's say a patient comes into the pharmacy and their blood pressure is 110 millimero ADG, but they're not having any crazy symptoms. What do you do?
First, double check that blood pressure reading. You got to make sure it's not a fluke.
Yeah.
Then ask them about their medical history, what medications they're on, any recent changes in their health or lifestyle.
And if everything seems okay and it looks like a legitimate case of hypertensive urgency, what then?
I would definitely talk to their doctor, explain the situation and get their advice. The doctor might adjust their medications or add a new one. They might suggest some lifestyle changes too. It really depends on the patient.
And of course, you would stress the importance of follow-up care, right?
Oh, absolutely. We want to make sure that blood pressure stays under control and that there aren't any complications developing. Now, before we wrap up this part, I want to mention a few specific things to think about for certain patients.
Okay, sounds good. Which patients are we focusing on?
Let's start with pregnant women or women who are thinking about getting pregnant. We know that ACE inhibitors and ARBs are a no-go in these cases. They can be harmful to the baby. Methyl-dopa is usually the best choice for these patients.
Okay, so a different medication for pregnant women. Makes sense.
Mm-hmm.
What other groups do we need to think about?
We also need to remember that different racial and ethnic groups can have different rates of hypertension and might respond differently to certain medications. For example, Black patients tend to have more severe hypertension and might not respond as well to ACE inhibitors and ARBs.
So tailoring treatment to the individual is key.
Exactly. That's what it all comes down to, personalized care. Now, I know we promised some fun facts about hypertension, and I think this is the perfect time for a little break from all the serious stuff. What do you think?
Ooh, fun facts. I like it.
Did you know that almost 1 in 3 adults in the United States has hypertension?
Wow, that's a lot of people.
It is. And what's even scarier is that many people don't even know they have it because there are often no symptoms. That's why they call it the silent killer.
It really emphasizes how important those regular blood pressure checks are, even if you feel totally fine.
Absolutely. Finding it early and treating it is the best way to prevent problems down the road. Okay, ready for another one?
Get me?
Here's a fun one. Your blood pressure actually goes up and down throughout the day. It's usually lowest when you're sleeping and highest when you're awake and moving around.
Well, that makes sense. Our bodies are working harder when we're active.
Exactly. And those ups and downs, they're totally normal. What we're concerned about is when it stays high all the time, even when you're resting. Okay, one more fun fact. This one's about lifestyle. Did you know that just listening to calming music can actually lower blood pressure?
Wait, really?
Yep. Studies have shown that it can help lower stress and anxiety, which are both linked to high blood pressure.
So putting on some chill music can actually be good for your heart. I like it.
It's like a prescription for relaxation.
Exactly.
And speaking of lifestyle, here's another one. Eating dark chocolate can be good for blood pressure, too.
Now, wait a minute. Isn't chocolate supposed to be bad for you?
Not all chocolate. Dark chocolate, the kind with a lot of cocoa in it, it has these things called flavonoids.
Flavonoids, okay.
They're plant compounds that have antioxidant and anti-inflammatory properties.
So they're the good guys.
Exactly. And studies have shown that they can help improve how your blood vessels work and might even lower blood pressure.
So enjoying a little piece of dark chocolate every day could actually be good for your heart. But I bet, like with most things, moderation is key.
Always. You can definitely have too much of a good thing.
Yeah.
Okay, one last fun fact. This one's about taking your medications. Did you know that something as simple as using a pill organizer can make a big difference in whether people actually take their medications as prescribed?
Yeah. It helps keep everything organized.
Right. It can be a game changer, especially if someone's taking multiple medications. It helps them keep track of what to take when, prevents them from missing doses, and helps them avoid accidentally doubling up on their meds.
So a little organization can go a long way. Now, getting back to the serious stuff, I wanted to circle back to something we talked about earlier, the importance of working as a team to manage hypertension, especially those tricky cases of resistant hypertension. It takes a village sometimes, right?
Absolutely. And as pharmacists, we are in a really unique position to advocate for our patients and work with everyone on the healthcare team to make sure those blood pressure goals are met.
So how can we, as pharmacists, help build that team spirit?
Well, first of all, we need to build good relationships with the other members of the team, the doctors, the nurses, everyone. Open communication and respect are super important.
And I'm guessing regular communication with the patient's doctor is really important too, right? Like letting them know about any medication adjustments, potential side effects, or if the patient's having trouble sticking to their medication regimen.
Absolutely. Keeping those lines of communication open is crucial. Everyone needs to be on the same page, working together for the patient's benefit.
What about bringing in other professionals, like dietitians, especially for patients who are struggling with making lifestyle changes?
That's a great idea. A referral to a dietitian can be super helpful. They can work with the patient to create a meal plan that fits their needs, teach them about healthy food choices, and help them reach their weight loss goals. It's all about teamwork.
So it's about knowing our strength and our limits as pharmacists, and knowing when to bring in other experts to give our patients the best possible care.
Exactly. We don't have to do it all alone. Collaboration is key. Now, I know we've covered a lot of ground in this section, but I think this is a good place to pause for now. We'll pick up where we left off in the next part and wrap up with some final pearls of wisdom to help you ace that Naplex and excel in your pharmacy practice.
Sounds good to me.
Mm.
Okay, time to wrap up our hypertension deep dive. Ready for those final pearls of wisdom to help you conquer the Naplex and thrive as a pharmacist.
Absolutely. Let's shift gears and focus on some key takeaways for your pharmacy practice. Think of this as the highlight reel of everything we've covered.
Perfect. I'm all ears. Where should we start?
Let's recap those essential hypertension facts, starting with the fact that it's super common, but often silent,
Right.
It often goes undetected until it's already caused some damage, so routine blood pressure checks are absolutely crucial.
Screen, screen, screen. And while we know most cases are essential, meaning we don't know the exact cause, we always have to keep those secondary causes in mind.
Right. Things like kidney disease, sleep apnea, Even certain medications can be driving those high blood pressure numbers.
It's like a medical mystery.
Mm.
And once we have that diagnosis, we can't forget about the power of lifestyle changes as our first line of defense.
Absolutely. Weight loss, the DSH diet, regular exercise, and moderating alcohol, they all make a huge difference.
But medication is often needed, and that's where we need to be experts in all those different drug classes.
You got it. Thiazide diuretics, ACE inhibitors, ARBs, calcium channel blockers, beta blockers. Knowing all the ins and outs of those is crucial, both for the NAPX and for taking care of your patients.
And let's not forget about those special considerations. Managing hypertension in patients with diabetes, kidney disease, or heart failure, that takes some extra finesse.
It really does. And then you have those tricky cases of resistant hypertension, which often require a whole team approach.
Not to mention those hypertensive crises, knowing when to call for help right away versus managing it with oral medications.
It's a lot to remember. But you're clearly dedicated to learning all of this, which means you're on the right track to becoming a fantastic pharmacist.
We believe in you. And remember, learning doesn't end after you pass the NAPLX. It's a lifelong journey.
Absolutely. Stay curious, keep asking questions, and never stop learning. That's what makes pharmacy so rewarding. We're constantly growing and learning right alongside our patients.
Well said. I think that's a perfect note to end on. We've covered so much in this hypertension deep dive, from the basics to the complexities of managing those challenging cases. Remember, knowledge is power, and you've gained a wealth of it today.
And remember, this isn't just about memorizing facts for an exam. You're building the foundation for a career where you'll be helping people make important decisions about their health. It's a privilege and a responsibility, and one we know you'll handle with skill and compassion.
Couldn't have said it better myself. So to all our future pharmacists out there, keep those brains buzzing and keep those hearts healthy. We'll see you on our next deep dive.